Hi everyone, good morning. I'm Niharika Jha and this is my thesis project for Global Health MPS. So my topic is nutrition transition from 2013 to 2022 and its association with body mass index among participants of the Dhulikhel heart study. So here is the background. In last decade, traditional foods of Nepal like typical dal, bhat and vegetables have been replaced by processed foods such as noodles, beverages and other ready-made foods. Also, the restaurants and eating out culture is developing in these years. The STEP survey of Nepal found in 2019 that nearly 25% of adults in Nepal were either overweight or obese. Another study in 2017 compared the per capita energy intake of an individual in Nepal from 1970 to 2010, and it was found huge difference in the per capita energy intake from 1970 to 2010 in Nepal. So here is the significance and objective. So among various factors associated with being overweight, one important factor is nutritional status. And no study in Nepal has measured changes in nutrition in terms of nutrition transition and association with overweight and obesity in Nepalese population. So my first aim was to measure nutrition transition in terms of change in dietary intake among the participants of Dhulikhel heart study. And my second aim was to assess the association between 9-year dietary change and body mass index among the participants of Dhulikhel heart study. About Dhulikhel heart study. So it was a cohort study of cardiovascular disease and its risk factor among all the adult population of Dhulikhel municipality in 2013. The study was comprised of data collected on various areas like demographic, socioeconomic, medical history, food and nutrition behavior, physical and cognitive function, and also anthropometric measurements. The second stage of DHS began in 2022 among the same population with the same tools. About the methods, this study used a longitudinal retrospective research design, specific data sets, food and nutrition, and anthropometric assessment from the DHS 2013 and to DHS 2022, also called Wave 1 and Wave 2, were extracted and used for this study. The people residing in the Dhulikhel municipality were the study population. DHS participants who had participated in both the DHS study were only included in this study. So there were 307 participants included for the final analysis of this study. About the tools, so DHS used a validated semi-quantitative food frequency questionnaire that contains questions on the average consumption frequency during the past years for 115 commonly consumed food items. Participants indicated their answers for frequency of food intake in times per day, per week, per month, or per year, or as never. Then we converted all the answers as times per day or as never. For portion, DHS used pictures of food indicating food serving of each food item. The picture is like this. It denotes food servings in half, 1 and 1.5 and 2 servings, and all their answers were converted into grams per day and also in calories per day for each participant. Then this study also used weight and height data to measure BMI of the participants calculated as weight in kilograms divided by height in meters square. For the data analysis, the data were analyzed with RStudio. So I have like more than 1,600 codes for the analysis. It's funny. Then descriptive statistics were done for the demographic variables that includes counts, percentages of 4 categorical variables, and means standard deviation for continuous variable. And then the global diet quality scoring system was used to assign the nutritional score to each participant based on their food consumption, grams per day, and compare the score from 2013 to 2022 among the participants. And then multivariate regression was used to show the relationship between nutrition transition score and BMI of the participants. About the GDQS system. So it is a food-based metric consisting of 25 food groups, 16 healthy food groups, 7 unhealthy food groups, and 2 food groups, red meat and high-fat dairy, that are unhealthy when consumed in excessive amounts. For 24 of the GDQS food groups, 3 ranges are used in scoring the metric: low, medium, and high. For 1 food group, high-fat dairy, 4 ranges of consumptions are used: low, medium, high, and very high. The points of the healthy food groups will increase for each higher quantity of consumption category, and the points of unhealthy food groups will decrease for each higher quantity of the consumption, after which the point will decrease. So in this study, each respondent received points for each GDQS food group according to the quantity of consumption consumed for that food group. The GDQS has a possible score of 0 to 49. Population-based cutoffs of 15 and 23 were identified for the GDQS as per the guideline to allow for reporting the percentage of population at high risk of poor diet quality outcomes, that is GDQS less than 15, and the percentage of population at low risk of poor diet quality outcomes, that is GDQS more than and equal to 23. And then for clarity, higher consumption of healthy food groups and lower consumption of unhealthy food groups represents the healthier eating patterns. Similarly, higher the score of healthy and unhealthy food groups, healthier nutrition behavior among the participants. Now the results. So first table shows the general characteristics of the participants. Mean age in first wave is 42.8 years, whereas in second year is 50 years. About 56% of the participants were male and 65% of them from Newar ethnicity. The picture shows the BMI categories trend over time, and we can see overweight and obesity were in increasing trend, whereas underweight and normal weight were in decreasing trend. The second table describes the percentage of DHS participants eat outside in a week. So 12% in first DHS and 27% in second DHS go outside 5 to 7 times in a week for meal. And then 30% of the participants were hypertensive from the second wave. This table shows the frequency and percentage of participants based on their food consumption in grams per day. We can see here high consumption of deep orange fruits decreased from 53% to 24%. High consumption of dark green leafy vegetables decreased from 61% to 30%. High consumption of legumes also decreased from 98% to 31% over time. Similarly, in unhealthy food groups, low consumption of high-fat dairy decreased from 100% to 85%. Low consumption of sugar, sweetened beverages decreased from 100% to 37%. And low consumption of white roots and tubers decreased from 92% to 16% over time. Now the mean GDQS healthy score decreased by 2.4 from DHS 2013 to DHS 2022. Similarly, the mean GDQS unhealthy score decreased by 1.3 from 2013 to 2022. And then overall, the mean GDQS total score decreased by 3.7 over time. And around 6% of the DHS Wave 2 participants were at high risk of poor diet, which was 0% in 2013. Now, if we see the regression model between BMI and total GDQS score after adjusting for age, sex, ethnicity, education, and total food consumption in calorie, we can see that in wave 1, higher the GDQS score, lower the BMI by 0.04 kg per meter square. In wave 2, it's opposite. So higher the GDQS score, higher the BMI by 0.2 kg per meter square. But it's significant, like the p-value is 0.005 in DHS wave 2. Now, if we see the adjusted multiple regression model of BMI and 9-year nutrition transition score, we can see that the shifting in nutrition transition score 1 point higher the BMI by 0.09 kg per meter square, which is opposite to our hypothesis. So there is no similar research in Nepal to compare our study findings, but we can articulate the reasons for these unexpected results, and that could be might be the small sample size of our study. And then some participants with BMI higher than 50 kg per meter square might also affect our result. And then it is also possible that errors in measurement during the data collection occurred, and also probably the manner in which FFQ data were collected may not be compatible with the GDQS scoring system. And also maybe like we did not include important variable like physical activities and others into the models, maybe also affecting our results. So hence we plan to rerun this analysis when the DHS has completed data collection to learn if a larger sample size or inclusion of other important variables may result in different findings. So for now, the conclusion of this study is although the relationship between nutrition transition score and BMI was not significant in this study, we documented a pattern of nutrition degrading and more unhealthy food intake increasing over time. Now, at last, I would like to acknowledge my supervisor and mentor, Professor Annette, for regular guidance and supports, and Dr. Arsana and Dr. Mandy for all the guidance throughout the program, and then Department of Global Health, University of Washington, Dhulikhel Hospital, and also the CMRTP and team, and then at last my family and friends, of course.